All right, we can go ahead and get started. Can you guys see my screen all right over here?
Yes.
Perfect. I've been messing with hiding this thing, so I think I forgot how to get it back if I need it. So today we'll be talking about behavioral symptoms of dementia and just what are our general approaches to that. I would say this is one of the more important topics that we have in the kind of years session. So I don't have any disclosures for this talk other than there will be clearly off-label use because there's not many that are approved for these indications. So I do want to just kind of point out a few of those behavioral symptoms we typically see. What are the most common ones? What are some less common ones? We generally group these as you'll hear different terms used, but behavioral and psychological symptoms of dementia. I mean, we think of other diseases, dementia being a disease, right, of the brain. I mean, these are symptoms of the disease, right? That's how we have to think of them. And then if there are treatment options, we need to be thinking about how to best treat them. I will say incorporating a multidisciplinary approach is key. So, if you've got social workers that are able to at least talk with caregivers about these are some of the symptoms we typically see, right? These are some strategies that our families have found useful, because those non-pharmacologic strategies by far and away are much more useful than any medicines we can throw at these diseases, right? So we're going to highlight that, but then when to use medications, which ones do we recommend when we need them? So the prevalence of these symptoms are extremely high. Some would suggest they're 100% or at least 99%, at least at some course in the progression of these neurodegenerative diseases. It is one of the two most common reasons for placement, incontinence and other hygiene-related issues being the other one, or instability from falls and concern from that standpoint. But this is by far and away one of the most common reasons. Individuals with these neurodegenerative diseases, especially if they have neuropsychiatric symptoms, have a high co-occurrence of depression. And so I think that's something that we have to remember. It is one of those things too, where if you ask them, are you depressed? They'll say almost universally no. So that's not how we are able to rely on that information. Having these symptoms has a greater impairment in tasks of daily living. There's more rapid cognitive decline seen, although some of that may be due to many different factors. Overall quality of life, earlier institutionalization, like I mentioned in the previous slide, increased number of facility evictions. So obviously, if they are placed in a facility and there's significant behavioral symptoms, there's multiple moves occurring, sort of a spiral effect that we see. Higher healthcare costs, obviously, and this is one of the symptoms that's most related to caregiver burden as well. And so yeah, the one that you can't really rely on a PHQ-9 in someone that has poor insight, right? And the I am not depressed line is used a lot, and I would say it often doesn't show up the same in these diseases. So I would say the most common symptoms we see is irritability, extreme irritability sometimes, anxiety, agitation, right? Those are usually our signals that something's going on. Sometimes patterns like times a day being worse than others can be a signal. Variable mood, especially with that irritability. When there's a lot of frustrations with the symptoms, maybe it's getting the right words out, maybe it's memory, right? Especially, sometimes it's sort of what is being said in the moment with the caregiver and loved one. Sometimes it's just routine being broken can trigger a lot of frustration and anxiety and irritability. So, and I would highlight that SSRIs can specifically help with this irritability, anxiety, agitation aspect much more than it can help with apathy and sort of the more classic, negative symptoms of depression. And some SNRI medications, at least in some patients, can worsen those specific symptoms. So we have to keep that in mind too. So on that note, so some meds that can make things worse, well, it really kind of depends on what's the diagnosis, what's going on, right? So like donepezil, which is a acetylcholinesterase inhibitor boosting acetylcholine, that can worsen behavioral symptoms frequently in frontotemporal dementia, because frontotemporal patients don't really have a cholinergic deficit. SNRIs, like I mentioned in the last slide, may increase hypervigilance and agitation, compulsiveness. So extra norepinephrine, which is the SN component of SNRI, may not be a good option. For patients with Alzheimer's and Lewy body disease, though, anticholinergics are going to worsen hallucinations, confusions, delirium. So those should absolutely be avoided. We're dealing with neurotransmitters here, and there's some aspect of each disease affects neurotransmitters slightly differently. So like one of the hardest hit areas in the brain that I'm circling right here, and these two biggest green blobs, that's the nucleus basalis minor, and that's like one of the biggest regions affected by Lewy body disease and Alzheimer's disease. So these acetylcholine projecting neurons to the brain are drastically hit, and they're very sensitive to anticholinergic medications, and that's why we use the procholinergics to help boost it. That may be different than the circuitry that's hit in norepinephrine. So you can think of this also as an imbalance. If they've got normal norepinephrine levels going about, but they're deficient in acetylcholine, that's going to cause an imbalance, and sometimes that's why we see behavioral symptoms emerge as well. And that's also why sometimes these behavioral symptoms can be treated just simply with donepezil and other acetylcholinesterase medications for those patients where it's really that imbalance problem that really can help, right? Serotonin's obviously involved here as well, and so we talk about SSRIs a lot here. As far as part of the whole point of these courses is for recognition of different diseases, right, and differentials.
I'm good.
Somebody's not, yeah, there we go. For Alzheimer's disease, I mean, when we think of like the behavioral symptoms, the anxiety, irritability, frustration is by far and away the most common symptom we see. When you're starting to get visual hallucinations, we have lots of fluctuations occurring. RBD is REM sleep behavior disorder or Parkinsonism, right? We're thinking about something slightly different than Alzheimer's disease. That's Lewy body dementia until proven otherwise. And you often have more paranoid delusions, misidentification syndrome. So spouse is someone else, right? And these different misidentification things that we see. If there's been a history of stroke or a lot of vascular disease, vascular dementia is something we see. There's not really specific symptoms associated with that, just so you're aware. But we see like lots of changes in behavior, personality, then we're thinking more of frontotemporal dementias. And that's where we get some more, less common symptoms, but can be quite extreme, of socially inappropriate, hypersexuality, compulsive behavior, hyperorality. So, and I know we have a whole talk on Lewy body disease, but I think it's just important to reiterate when we're in this talk of behavioral treatment. For that anxiety, irritability, depression, we do try to use low doses of trazodone if more for a Band-Aid approach. But really the better option is a longer term SSRI, and then switching someone from an SNRI to SSRI if this is one of the symptoms that is a major issue. And so the ones that we typically use that are well tolerated is escitalopram or sertraline. For the psychosis, delusions, hallucinations, paranoia, I should put in there too. So quetiapine is our usual mainstay, at least for the Band-Aid approach, but at very low doses, right? Sometimes we have to get to more moderate doses, but we try to stick with low doses if possible. And these are the patients that really should not be getting dopamine blocking agents. You can make them significantly worse by doing that. And long-term though, really like I mentioned earlier, those acetylcholinesterase inhibitors are our mainstay. There is an approved, so FDA-approved medication for Parkinson's disease-related psychosis. Pimavanserin is pretty well tolerated, and this is actually a good option for some patients. It works quite well, but can be expensive unless there's some cost-saving programs involved. So, and I would say most of this list, these principles hold true for Alzheimer's disease for the majority of cases as well. I would add, though, I should have put this in here. So for Alzheimer's disease, risperidone can work pretty well. That is a dopamine blocking agent. But if you're like pretty certain that there's no Parkinsonism or Lewy body disease, risperidone can be a good option here. But you'd want to watch out for side effects of Parkinsonism. So to name some of these symptoms in a little bit more detail, I think that sort of agitation, irritability, everybody's seen that. It tends to be underlying anxiety, frustration of the symptoms, obviously, and anger can ensue. We see a lot of apathy. That's an extremely common symptom associated with these diseases. That's probably more in line with depression, and reduction in hobbies are some of the signs that we might see. The watching TV all day, withdrawing from social activities, and then psychosis. These are probably the three top ones that we see, at least groups of symptoms, with this one being more associated with Lewy body disease. So traditionally, what do we do, right? And I should bold and underline, right, that this is not the recommended approach. But in the hospital, patients just get typical antipsychotics, and often these are prescribed in the outpatient setting too. These are medications like haloperidol or olanzapine or risperidone. I just caution with this, risperidone being the one that's probably a little safer than the other two, but many patients have co-pathology. So even if their cognitive testing looks like Alzheimer's, if they've got some other REM sleep behavior disorder and other things that suggest maybe co-pathology with Lewy body disease, which is the second most common cause, these medications can still significantly worsen them. Benzodiazepines as well. So, the sort of chances of worsening balance and confusion, these sort of, it's not a great long-term option. It's probably still better than Haldol, especially like in those hospitalized patients, but you may even worsen delirium with benzodiazepines, at least acutely. But in some instances, they're absolutely necessary, especially when you only have IV available. But typically in outpatient settings, we have some better options. So better Band-Aids that we generally will use. So very low doses of trazodone. When it's based, unfortunately, we only have a 50 milligram tablet. I wish we had a 25, because sometimes I'll even try to go as low as 12.5. That can be very hard to split twice. But starting with 25 milligrams, and that can be more of twice daily or 3 times a day, depending on sort of when are these events happening. And it can be as needed or scheduled if it's something that's kind of regularly happening versus, well, we're worried about this time because we're going to be packing for this instance, right? We're going to be flying for this. Those are more of as needed. And those would be much preferred over benzodiazepines. So that's more for the anxiety, agitation, irritability side of things. For paranoia, like I mentioned earlier, quetiapine. But again, starting very low and going slow, right? We rarely ever get above 50 milligrams per dose. And usually we're in the 12.5 to 25 milligram range. You do have to know, any of these atypical antipsychotics do have a black box warning. However, usually when we're reaching for these things, the benefits far outweigh the risks, and those risks of increased mortality are quite low if they're used appropriately at low doses. And if they've got an extensive cardiac history, especially if you've got QT prolongation, then consider an EKG would be recommended. For longer term solutions, we've mentioned these two, but I'll just point them out again. Sertraline and escitalopram are better options for the majority of our patients in this population. And I would say that's really for all-cause dementia, even for FTD, AD, DLB, vascular. Paroxetine or Paxil we'll see prescribed often, but this one specifically has some anticholinergic properties to it. It's actually quite anticholinergic. So that should really be avoided in DLB and It does have pretty good uses in FTD, and it's one of the SSRIs that's been best studied in FTD, so that would be reasonable to do. And then sort of balancing the cholinergic problems, right? So like oftentimes we'll see patients that are having increased confusion. I had a patient a couple weeks ago that was given one dose of oxybutynin and had multiple days of delirium, right? And so these patients can just be very sensitive to anticholinergics, and so we just have to be mindful of that. But then we're also trying to optimize the boosting of acetylcholine, right? There is a new drug on the market. So this new drug that you'll see headlines of, the FDA approves first drug to treat agitation in Alzheimer's. It's this drug on the left here, this brexpiprazole or Rexulti. It's basically works on the dopamine and serotonin receptor. Here's the cost though, so I haven't prescribed this yet. A very similar drug is available generically for much cheaper options. I still don't really ever prescribe this either, but I've seen it used in some patients being helpful. This one's a little bit dirtier of a drug, meaning it binds to a number of other receptors. So this one may be a better option in the long term, but obviously probably not at that cost. So I generally haven't prescribed these yet, but it's nice that we potentially have some other tools in the toolbox to consider. For the anxiety depression side of things, I really, the non-pharmacologic is still by far and away the most common thing that we're recommending, right? And so, if there are certain things that are triggering those irritability, anxiety episodes, right, identifying those is key. And for sort of the apathy and depression, really trying to find ways to engage them in purposeful activities, right? Whether that be volunteering or church or social groups, whether it be an exercise class, a cognitive group class, right? Something that engages the brain and has a purposeful meaning to it, right? From a pharmacologic perspective, we use SSRIs. There is another one on here that has been shown to have cognitive benefits in 65 plus year olds. That's vortioxetine, but and Trintellix is the brand name of that. The reason it does that is because it actually has procholinergic effects. So that's kind of interesting to note, but it would be important to know that if you've got someone already on donepezil and then you put them on that and they get diarrhea, well, there's probably a good reason for that because of this effect. Trazodone, again, low doses. Sometimes it's just really good to use this at bedtime too, because that's what's keeping them up at night. So that's sort of insomnia side of things, the mind racing phenomenon. Trazodone works best for that. So some other good options. I've had some patients undergo transmagnetic stimulation. This is FDA approved for anxiety depression. You do have to fail 2 standard medications to consider that. But if we're stimulating areas like the prefrontal cortex, that can have definite benefits for brain networks that are undergoing changes. Agitation wise, so sometimes I've had patients that have been agitated. They might have primary progressive aphasia. They can't necessarily say or voice what exactly is wrong, and it comes out just as agitation, and in reality they were having a lot of pain, right? And so it was just Tylenol, scheduled Tylenol, not as needed because they can't ask for it, right? But scheduled Tylenol, and then the agitation resolved, right? And so screening for pain is important. Also involving them with the certain activities, right? Because sometimes there's agitation out of boredom. And then so certain music activities, exercise, especially in, these need to be implemented more in, our retirement communities and our memory care units. From a pharmacologic perspective, again, we're using SSRIs predominantly. The newer ones that I mentioned in the previous slide, so the one that's actually FDA approved is this Rexulti. I think some future directions. So I've seen like some preliminary data on, and I've had patients tell me it's been beneficial, right? It's more from an anecdotal perspective that CBD can be helpful. I generally don't recommend CBD plus THC because the THC component could have its own negative effects on memory and paranoia, but the CBD component might have a role for agitation and anxiety. For the apathy perspective, so some of that is like a almost just having a tailored program, right? Like this is what we're doing for the day, right? These more structured routines with good cueing, not I want you to do this or you need to do this. There are ways that that message can be conveyed, without creating a negative reaction. But having more structured, tailored activities can really help with this symptom. We have, at least in some patients, tried stimulant medications. I generally favor modafinil over other stimulants, but for some patients that can help. If they've got a lot of other behavioral symptoms like agitation, aggression, then sometimes that's not the best option to be giving them a neurostimulant, but it is something we've considered in some patients. I think these are potential targets for transmagnetic stimulation too, especially in the frontal brain networks. And then oxytocin's being looked at as well. We've talked about this one mostly, but I want to highlight the non-pharmacologic aspects. So two quick stories. So I had one patient that around a certain time in the evening kept having a lot of agitation, would pace around the house, would sometimes go outside the house. There was a lot of concern of them tripping and falling, especially as it was getting dark. And I need a medicine doc to calm them down in the afternoon or in the evening time. And then we had our social work team talk with them, kind of figure out what time this was exactly happening, what might be going on. And turns out they were just seeing their reflection in the window, right? And they were quite paranoid that there was someone outside the house. And that was the trigger of what was causing all this, right? So we could have thrown a bunch of medications at this with causing side effects, right? When the actual solution was to close the blinds, by 6 p.m. to make sure that didn't occur. Similarly, an episode of visual hallucinations with, watching the nightly news, they were seeing Ukrainian children like in the living room. It was like, you just really have to avoid those programs, right? That's just not going to be a good option for them, especially in the evening times, right? From a pharmacologic perspective, though, these are the ones we mentioned. I should put risperidone here more than olanzapine, but these are more of, I would say these are more for like what we would use in FTD, whereas I have that other slide more for Lewy body patients. For sleep, I think sleep's extremely important. So sometimes when we say, oh, well, there's good days and bad days, I would bet that some of that comes down to how well they slept, and not just quantity, but quality, right? So it's very underdiagnosed, but sleep apnea is probably highly prevalent, especially when we're getting daytime sleepiness being part of the problem. So these sort of reductions in daytime naps, especially with stimulation activity, can help the nighttime sleep. That's where this daytime physical activity comes in. Limiting caffeine, to certain times of the day, limiting the amount of trips to the bathroom at night because of drinking too many liquids at night, limiting screen time beforehand, before bedtime. But really, it comes down to having a stable routine and some sort of calming routine before bedtime, not fear-inducing shows like the nightly news and things like that, right? From a pharmacologic perspective, though, I think probably number one on the list is treating sleep apnea when it's present. Part of that too, and we'll have this in another talk, right, when we specifically talk about sleep, but it is potentially something that's going to worsen and accelerate their disease process, right? But it also has implications on how the next day is going to go if they have a really poor night of sleep. Melatonin can be useful, especially if it's a circadian rhythm issue. It can be helpful for REM sleep behavior disorder as well. Trazodone is our usual mainstay for the mind racing phenomenon, keeping folks up. Longer term agents like SSRIs can also help with that symptom. Prazosin I mentioned here just because it is approved for and has been useful for like, especially PTSD related nightmares. So we think it probably lowers some of the adrenergic response to those nightmares, but that can be helpful in some patients. So a few other symptoms here. So things that are more associated with FTD, when we think about what does the frontal lobe do? Well, one, it's involved in executive function, that sort of ability to have good judgment and planning, decision-making. So folks are at risk for scams with that, right? So having that's a non-pharmacologic strategy in place, right? To try to avoid the financial risks of scams. Cognitive flexibility. So when those routines are changed, that can be very difficult. That can create a lot of behavioral symptoms. And then the frontal lobe is basically the filter, right? So what are the consequences of saying what I'm thinking, right? And this can lead to socially inappropriate behavior, basically disinhibition, impulsiveness, carelessness, and rash decisions. So those non-pharmacologic strategies, I mean, like in more severe cases, especially in more advanced stages, skin picking behavior can be a major issue, right? So having clothing barriers, having things in the way, right, of that skin picking, and obviously good skin care to make sure dryness isn't an inciting reason why they're having those feelings. We've had patients that have just continually drank way too much water to the point where it would be dangerous, right? And so they shouldn't have access to just free standing water, right? And so it's more of an access issue there. We see that too with dietary changes. So from a pharmacologic perspective, you may need much higher doses of SSRIs. So like, OCD type doses of sertraline are much higher than our standard doses. Mood stabilizers, I should have put some in here, but things like Depakote we'll sometimes use if the first line agents aren't working, or lamotrigine. Some of the atypical antipsychotics can worsen these behaviors. And then, transmagnetic stimulation is approved for OCD, so some of these behaviors might be reasonable to target for that, but in dementia, it's not entirely well understood if that would be a good option. For empathy and sympathy, so from a non-pharmacologic perspective, really, and this is pretty much the only thing we have, is for family to be aware of why that might be happening, right? And education on that, right? It's not necessarily that they don't love you anymore, right? Or that this has changed, like this is part of what the frontal lobe does. And so we don't really have any medicines for that. There's some that have at least looked into oxytocin, which is sort of the love hormone, right, in the brain. So could that be potentially an option? From the hypersexuality standpoint, I mean, this can be a major issue, especially in FTD. And we don't have great options there. From a lot of it is having, the sort of avoiding situations is really our mainstay. But sometimes we'll get to higher doses of SSRIs that we try to pick ones that have the side effect of decreased libido, and try to utilize that. And that can work in a certain percentage of patients. So citalopram, and I think I had on the list too, can't remember, I think it was Proxetine too, had higher rates, but citalopram is usually what I'll try to use first. For hyperorality or just eating, like you might just hear a story of all the cookies and chips are gone in the house. Really that is an access problem, right? So their frontal lobes are not fully working. They can't limit what they're going to be doing, what they're going to be eating. So if you've got bags of carrots and broccoli and stuff around rather than the sweets and junk food, then that's really our mainstay of treatment for that. Sometimes scheduled treats can be helpful there. Certain vitamins, if they're really restrictive with their eating diets, is important to think about. Interestingly, like topiramate can be an appetite. It could basically depress appetite, and so that has been used in some patients. The newer agents, so these newest weight loss drugs, may be able to suppress appetite there, but it hasn't really been studied in this specific population. So we are right at 30 minutes. I'm going to just summarize things a little bit here. So some do's, right? You have to search for and eliminate triggers. So sometimes when I hear a story of like there's been a sudden change, yesterday we were doing pretty good, and then today all these different behavioral symptoms have like shown up. That's not a typical progression of dementia story, right? That's something else is going on. UTI is a very common, or viral illness trigger for those types of things. Sleep apnea. So maybe they didn't treat their sleep apnea. They're not treating it. They had a poor night's sleep, insomnia, and then certain medications, right? I mentioned that's one dose of oxybutynin, all of a sudden things were drastically different, right? They didn't have a stroke. They have a very sensitive cholinergic system, right? Informing caregivers and involving them, right? So that's key. They're the ones that are seeing these symptoms on a daily basis and trying to figure out. Sometimes it's, well, what time is it happening? What are the common things that are going on when these happen? Trying to pinpoint those as much as possible is extremely important, especially when we're trying to say, well, these are at least some things to consider from a non-pharmacologic perspective. Really optimizing the medicines that we do have, right? So the cholinesterase inhibitors and memantine, and then utilizing those non-pharmacologic approaches. And if you are going to start medicines, starting low and going slow, right? And then monitoring, and then de-escalating when needed. So it's really the opposites here in the do not column, but I think it is important to remember that we're dealing with patients that have increased sensitivity to medication side effects. So starting at low doses is important. And I would highlight too, really just trying to de-prescribe any of those medicines that might be altering mental status, especially anticholinergics. So I will stop there. Oh, there's, I got it back. Just take a peek at the chat here. So yes, I love that, Dr. Quo. So I should have put constipation on there. That's a good one. So UTI, pain, constipation. Constipation can be a very common symptom, and so nondescript abdominal pain can be a way that presents, right? All right. Any other questions at all? I think one of those things too is like we have all this we have all this like don't treat asymptomatic UTIs, which I think is a great idea. But when you have patients that are in delirium and they can't tell you their symptoms, that sudden onset of delirium is your clue, right? That should be at least strongly suspected to be UTI, and if they've got evidence of pyuria and fouls, basically a lot of the changes that we sort of think of, well, that might be asymptomatic bacteria. Well, probably a good trial to see if it helps with treatment. And then we'll see recurrent episodes of delirium, UTIs, right? And then that's where really trying to highlight the importance of hydration and all the things that go along with that, because that can be a common reason why we're seeing recurrent UTIs. So one question here. So at what age would you not start Aricept, or years of life left? So Carla, that's a good question. I mean, I think part of your question is disease stage more than age. I don't think there's any age I would not start it in. Some people might, I mean, it is approved for mild to moderate dementia, but I think it really helps across all spans of the disease. So I don't really have a limit. It might be one of those where I would counsel them on, I don't know if this is going to have much effect, but let's trial it first and we can always come off of it, right? Especially if we're, I mean, I'm not going to be able to do that. 90-year-old beginning to get forgetful. I was thinking it more of it if there are specific like hallucinations and other things going on like at later stages. If you listened to my last talk, I do suggest it for more of a mild cognitive impairment range, but your question is actually a lot more complicated than it seems at first, because 90-year-olds with early amnestic symptoms, they might have something completely different called late disease and not Alzheimer's disease, and I probably wouldn't use it in that individual, but that becomes a much that's a patient specific question that I can't answer. Is so like if you're over age 85 and you're just now getting symptoms, there's actually a good chance it's not Alzheimer's disease. So it's kind of like a 50-50 shot at that point. So there's a medication that helps with memory issues with vascular dementia. So Tracy, I would direct you to our talk last time on cognitive medications, but in summary, no, but it's not always just vascular dementia. So if they've got copathology, vascular dementia plus Lewy body disease, yes, they should be getting medications. And similarly, if they have vascular disease plus Alzheimer's disease. So copathology is extremely common. But if those have been like completely ruled out somehow and it's only vascular dementia, yeah, there's no medications that can help memory for that. Yeah, that's I'm not gonna be able to answer that question. That's part of our whole course. So I would look back at prior talks. So all right, I'm going to hop off. I have to run upstairs. Thank you all for joining.